Brittany, do you want us to start?
You can go ahead and start, Dr. Davis.
Okay. Okay, well, welcome everyone to the 2022 Debbie's Dream Foundation Virtual Stomach Cancer Educational Symposium. My name's Jeremy Davis, and I'm a surgical oncologist at the National Cancer Institute, which is in Bethesda, Maryland, and I'll be moderating today's panel discussions. Before we get started, though, I want to thank Debbie's Dream Foundation and Andrea Eidelman for inviting me to participate. It's always important to share information, not just for education, but for stomach cancer awareness. Why does it say show my screen? Do I want to show my screen?
No, you're fine.
So for this first session, I want to welcome and also thank a couple of our speakers from this morning, Dr. Galen Leung, who spoke on the role of surveillance and endoscopic management of early gastric cancer. And then also welcome and thank you to Megan Roberts. She's a senior genetic counselor from GeneDx for presenting on hereditary gastric cancer. And then before we get started with questions, I'll welcome our patient panelists. We have, in no particular order, Angela Huang, Amanda Johnson, Brian Shigola, and Amy Jacobs. All are stomach cancer survivors, and we're so excited to have you all with us today to help us talk about some of these issues that started off this morning. So it's now time for questions, and what we'll do is we'll have the panelists weigh in based on their experience or their expertise on various topics. And since I'm the moderator, I get to start off. So one of the things that I was thinking about, and we were just talking about before we went live, is I had asked Dr. Leung, what do you think are the most important questions that patients should ask their doctor, especially if the doctor suggests that maybe their stomach cancer is amenable to endoscopic resection? What can you tell us is your advice?
Yeah, thank you, Dr. Davis. I think that's an excellent question, and that's why I usually have patients see me in clinic before they schedule their endoscopic resection procedure. Because endoscopic resection can be potentially curative, can be very beneficial, but in the right indication, in the right setting, in carefully selected patients. So when patients get referred to me for EMR, endoscopic mucosal resection, or endoscopic submucosal dissection, I kind of go over them that it's important to ask me, what are the indications for endoscopic resection? In carefully selected patients, this can be curative of their cancer. But in not carefully selected patients, this can lead to disease recurrence later on, lymph node metastasis, to the point where even sort of standard therapy is not indicated anymore. So that's an important question. What are the indications? Another is sort of what are sort of the statistics on sort of number of procedures performed, the rate of complete resection, because I think those kind of demonstrate, because ESD is a technically complex procedure. In the East, it's sort of done more often. So it's important to know that this, and at West, it's sort of catching on. So I think it's important to know how many of these procedures have been done, and also how many of them have had complete resection rates. That way, it speaks to the sort of technical feasibility of the procedure. Also, is the endoscopist selecting the right patient for the procedure? Because some patients who have deep cancers, ESD should not be attempted. If it is attempted, it leads to incomplete resection. Other things are basically safety of the procedure, what's the follow-up? Given that endoscopic resection does provide a smaller margin of safety compared to surgical resection, it's important to have very close surveillance afterwards, such as another repeat upper endoscopy in 6 months.
Excellent. Thank you for that. Now, I do have a kind of a follow-up question that's still related to endoscopy and really screening or surveillance, and then this will tie in a little bit to what Megan Roberts spoke about in terms of risk and specifically inherited risk. So, and I want to get our patients to weigh in on how they came about getting either their endoscopy or questions that come up after diagnosis about, well, should any of my family members get endoscopy? So the first question that I have relates to, let's say, Megan Roberts first, and that is, and Megan, I can't see you anymore, but I assume you're still there, is, what patients, or when patients get diagnosed with potentially an inherited form of cancer risk, gastric cancer risk, what kind of endoscopy recommendations are generally made from a genetic counselor standpoint, meaning, what kind of increased or enhanced surveillance? What comes to mind, obviously, is BRCA and breast cancer risk and surveillance with intense mammography or breast MRI. What do you say to patients when you're counseling them on inherited gastric cancer risk? Uh-oh,
Looks like we might have lost her.
Right while I'm asking her. Okay, so let's go back to Dr. Leung then. So when a patient comes to you and says, okay, I think I either have cancer in my family, gastric cancer in my family, or is there a role for screening? How do you approach that? Or how do you approach it in somebody who says, I'm worried about it and I have maybe a family history? How does that conversation usually go?
Yes, I think that's a very good question. Given that sort of in the US, there's no general screenings or endoscopy for the general asymptomatic patients compared to sort of some parts in the East, and where patients who basically get, even they're asymptomatic, just get a screening endoscopy at age 50. I think I'd go over sort of the risk factors for sort of gastric cancer. It's thought that certain demographics, especially those who come from sort of Eastern countries, may have a higher risk of gastric cancer, as well as those with a family history of gastric cancer, and definitely those with known genetic syndromes as well. So I think an asymptomatic patient who does demonstrate some worry about gastric cancer, who demonstrates a potential risk factor, either be family history or a certain demographic, I sort of tell them about the role of endoscopy in that situation. I do sort of offer it to them, saying that, well, if you go down this route, it sort of entails that it is a procedure, so there are risks and benefits of it. The benefits being we may potentially catch a precancerous lesion, which in that case we may need to sort of follow up with it every so often. So that's something they need to really understand. On the other hand, it also, like any sort of diagnostic procedure or test, there are false positives. So there's always the possibility that this may lead down to a road of additional testing, more invasive procedures. But in the end, it could be a false sort of positive result. So they need to sort of understand these risks as well as benefits.
Well, excellent. And before I go back to my question to Megan Roberts, this is for our patient panelists. And maybe I'll just ask generally, and this came through the chat, did any of the patients get genetic testing before they were diagnosed with gastric cancer? And I'll follow up on that. Or did any of you get genetic testing after diagnosis? and what was that experience like? I don't know who might want to weigh in first.
I'll go first.
Okay, you'll go first, and then Amanda looked like she was about to open her mouth. So go ahead, Angela.
Mine is quick. I did not undergo genetic testing before my diagnosis of gastric cancer, and I did undergo it after. And I believe that just entailed a blood test, and you would know, but perhaps just a test on the actual sample.
And we're going to come back to that in a second because I have a follow-up question to that. Amanda, what about you?
I was going to say I did test first because it was found in my sister. And so a letter went out to all of us saying we need to all be tested. So
what was that experience like for you? Not the actual test, but maybe just, learning about it and, following up on it.
It was a bit of a shock. I focused on my sister. We were, everything went really fast. So I was focusing on her and helping her. And then while she was recovering, I found out I was positive and then had my gastrectomy a month later. So, yeah, all three siblings tested positive, my brother too.
And just to follow up on that, on both you and Angela's comments, what was your experience, or did you interact with a genetic counselor for that process?
I did not.
I did. Oh, yeah, I did, but it was very minimal. When they found out I was CDH1 positive, they wanted me to make an appointment with a genetic counselor. She basically ran through all the family history and that kind of stuff, and then said, "You're the first person I've ever had with CDH1 positive," and we just kind of ended it there. There wasn't anything else to say.
Yeah. So before I ask Megan Roberts to comment, I'm going to say what I believe strongly is that genetic testing, especially germline genetic testing, right? Trying to figure out, what you carried with you from the day you were born is, that genetic testing should be done in the context of talking to a genetic counselor, ideally before you get tested. And on top of that, I think getting tested and then having not seen a genetic counselor, then even more important that you talk to a genetic counselor after the testing. And then Megan, I'll let you weigh in, but and you can share your thoughts on maybe the process and what it should look like ideally.
Sure. You can hear me okay?
Yeah.
Okay, great. I think ideally it is important to see somebody before, specifically when it's like a CDH1 mutation is known in the family. There's a lot of implications, I guess, for the family, which could be briefly discussed, but more importantly, who should be tested first and or the risks for other family members, and understanding the inheritance patterns and risks for those family members, I do think is important. I'm sad to hear you say that your genetic counselor had never seen somebody before with a CDH1 variant. I apologize for that. It is not the most common finding, I would say. Gastric cancer is not the most common referral type, but there are a good handful of us that have a good amount of experience with CDH1 and seeing patients with pathogenic variants in those genes and kind of dealing with that downstream. But yes, ideally, you want to see an individual either at the time of diagnosis so that you can help explain what that testing means, not only for them, but for family members. And then most certainly you want to see individuals, those other family members, so downstream. So, the whole goal behind genetic testing and genetic counseling for gastric cancer is to hopefully find what's going on in the family and then ultimately prevent in additional family members or get them to the right physicians that can help them manage the risk appropriately.
I have a follow-up to that. So for patients with CDH1 mutation, and I know some patients for a gastrectomy is pretty invasive, and I've encountered patients who don't want to go down that route. How does your conversation with them go about that?
So I will say I probably have more experience with CDH1 than the average genetic counselor. So for me, you know, I do know a lot of the literature that's out there, especially the stuff that's coming out from Dr. Davis's group, kind of suggesting that upper endoscopy and screening may be an option, specifically for families. You know, we're seeing a different phenotypic spectrum. So we're seeing a different clinical presentation for CDH1 in the last, say, 5 to 7 years than we historically have seen. And why that is they've started doing multi-gene panel testing, and which means that they're doing bigger panels with multiple genes, and we're not just targeting the CDH1 gene anymore. So we're identifying pathogenic variants in families that don't look classic. And when I say don't look classic, I mean they don't have this multiple gastric cancers and multiple generations. We're starting to see a lot of families actually that don't have any gastric cancer, but maybe are presenting with a few breast cancers in the family. And so they're not classic. And so, you know, myself, the conversation's a little different in that, probably also depending on the family history. You know, there's the IGCLC really kind of points out these days that there's kind of two different branches of CDH1 carriers. There's this hereditary lobular breast and no gastric or breast cancer, and then there's a truly hereditary gastric cancer. And so for those families that look truly hereditary diffuse gastric, you know, you do have this conversation of gastrectomy is generally that standard recommendation. But for those families that look a little less hereditary diffuse gastric, so meaning primarily breast, or you're not really seeing in either of these cancers, you have more of a discussion of upper endoscopy is definitely an option, and let's find you a gastroenterologist who has experience with this or has knowledge in screening individuals with pathogenic CDH1 mutations. Unfortunately, I think too many patients are kind of scared outright by not kind of knowing that this is an option, especially for those families where they don't look quite as classic.
Mm-hmm.
I don't know, Dr. Davis, you've done a lot of research. You could probably elaborate a lot on that.
Well, I could go all day long, but we're gonna switch gears, and because I think that's there's lots to discuss there. I do want to. There's some chat questions popping up in the chat, and I'm going to go to Amy or Brian since we haven't heard from them yet. Somebody wants to know, for instance, at what stage were you diagnosed, if you're willing to share that, and how long ago was it? I think Amy, I'm going to guess it wasn't that long ago, right? But do either of you want to comment on that?
I was diagnosed June 13th of 2018, so I'm almost at the 4-year marker. I was diagnosed at stage 4. And I had 2 failed chemos, and I'm on 3rd line Keytruda as a sole agent. I had a complete response. I'm an MSI high patient, which I understand is about 3 to 5% of us.
Yeah, so for those of you that obviously saw Dr. Moy's presentation or Dr. Klempner's presentation, which I thought Dr. Klempner's presentation along with Dr. Moy's were excellent. You're an example of somebody that has a type of gastric cancer that seems to respond particularly well to these newer immunotherapies called checkpoint inhibitors, which basically are ways of either ramping up the immune system or blocking the parts of the immune system that prevent, cancers from responding, to this immunotherapy type treatment. Brian, would you want to weigh in on kind of either your experience with either diagnosis, how it happened, what the experience was like in terms of either endoscopy or symptoms or whatnot?
Sure, yeah. I was diagnosed in June of 2019 as stage 4, so about 2.5 years ago. And the way it came about was I was experiencing some symptoms, like so many people do who get diagnosed at stage 4. They experience symptoms, and by the time they get it checked, it's already advanced, and that was what had happened to me. And so I took myself into the hospital, and that's where they actually found the cancer in a scan and performed the endoscopy there to confirm it. Since then, I've been on 4 lines of chemotherapy. At the start, I was HER2 positive, but then at some point last year, sometime around June, it changed and I became not HER2 positive. So I'm on a chemo now called paclitaxel and ramucirumab since October, and it's been a bit of a mixed bag. It's somewhat effective, but I also recently had a embolization procedure on my liver with some Y90 radiation, and we'll have another scan in a couple months to see where I stand on that. But these days I'm relatively stable, so yeah.
And back to the genetic testing question, did you ever have any genetic testing that, because I think somebody was asking about people's experience with any of that. Did you have any?
Not before my diagnosis, but after my diagnosis, I did at some point. I'm being treated at City of Hope here in Los Angeles, and they do that sort of thing in-house, and you know, they didn't really find anything in particular. I have, for example, I have a very low, what is it? I think the PDL1 marker is very low. So, but you know, I did pass that along to my siblings and have encouraged them all to get screened.
Okay. So I'm going to skip along. There was another question on here, and this relates, I think, a lot to what Amy and Brian were just talking about. And it says, what's available for patients with stage 4 gastric cancer, where maybe the tumor doesn't express HER2 or PDL1, because you just heard Brian mention HER2 or PDL1. And I'll make a comment, since Dr. Moy's not here, I'll step in as medical oncologist. That it is interesting that there are certain types of gastric cancers, especially the kind that spread to the abdominal cavity, that they don't often overexpress HER2 or PDL1. So those drugs that you've heard about this morning, like Herceptin or trastuzumab, or nivolumab or pembrolizumab, may not be reasonable treatment options. However, there are other treatments out there, and like Brian mentioned, Taxol and ramucirumab is FDA approved for treatment in metastatic gastric cancer. And then you also heard about emerging biomarkers and other clinical trials that are very, very interesting and potentially promising, such as the Claudin 18.2 antibody that I think Dr. Moy mentioned in his presentation this morning. So there are other treatment options. Many of them are still in kind of the clinical trial phase, but there are also kind of standard FDA approved therapies out there. And then somebody says, Amanda, that they love your earrings, and can you tell everybody the significance of the seahorse?
Well, the seahorse, basically it has no stomach. So it's become a mascot of CDH1 patients and people without stomachs. That's pretty much it. There's another, what is it? The platypus?
The platypus.
Right, is the other one. But seahorse seems to stick around mostly for most people.
Yeah.
Thank you.
Yeah, by the way, I had a patient from Australia bring me a platypus for that very reason. So here's a question. I want to circle back to Dr. either Dr. Let me see, which one is this? Okay, I'm going to go to Megan Roberts first. Brona asked, what's the best way to get insurance to cover genetic testing for family members of, let's say, a gastric cancer patient, or maybe somebody that's already got a known pathogenic germline mutation?
Yeah, so I think the best answer probably is to get a genetic counselor involved if you can. Most of us know either the insurance company's criteria that needs to be met and or laboratories and financial hardship programs that laboratories have. So I wouldn't put that burden on yourself. I would try to put that burden on the genetic counselor that you're seeing. That's a good reason, another good reason to use us to your advantage, right? Other than, you know, trying to understand the risks and the benefits of genetic testing, but then the risks for the family members is to let us kind of handle that for you. It's a lot easier these days than it used to be. Most the laboratories will actually offer pre-authorization through your insurance company and communicate with the patients and or family members, you know, whoever getting the testing, to make sure that they know of an out-of-pocket cost. And then most of them also have kind of programs where you can pay no more than a certain amount of out-of-pocket, even if insurance gives you a hard time about it. So I think my answer is let us kind of do that for you and give you that information that you need, but don't let insurance hopefully get in the way of getting any meeting tested done.
Yeah, my comment on that would be is that it seems like the cost of genetic testing continues to fall as the years go by, and I'm aware that there are some companies out there, at least if there's a known genetic mutation in your family, that oftentimes they'll offer reduced rates. But again, like Megan says, going through your genetic counselor, they know a lot of what the individual companies can and will do, because they're all a little bit different in that regard. Let's see. Let's go back a minute. There was a question up there, I think, about just how, and maybe this can be just a clarification by Dr. Leung about what makes it such that, you know, where you might switch between a recommendation for endoscopic resection and say, well, maybe this isn't a great candidate for you know, EMR or ESD, and you'd go to resection. Can you comment on either histologic subtype, like let's say intestinal versus diffuse, or you know, kind of, I think you mentioned earlier, depth of invasion?
Yeah, so I think in order to be a candidate for endoscopic resection, preferably by ESD or endoscopic submucosal dissection, depends on a couple of characteristics, sort of type of cancer, the size, and the depth. So for ESD or endoscopic resection, usually less aggressive types like well or moderately differentiated adenocarcinomas, those are more preferable for ESD, while poorly differentiated ones sort of may have a higher risk of lymph node metastasis. Also, the larger the lesion, there are two sort of issues. One is the ability to resect it completely. If it's a very large lesion, it may not be possible, or it might be very challenging to resect it in one piece and obtain sort of those safety margins on histological evaluation. But also with larger lesions, there is an increased risk of lymphovascular invasion as well. And last criteria is being depth of the invasion. So for cancers that are superficially invasive into the submucosal layer, which is underneath the top mucosal layer, up to sort of 500 micrometers, ESD can be potentially curative if the margins are negative. There are no signs of lymphovascular invasion. Deeper than that, into deep submucosal invasion, ESD is not ideal, because even if there is sort of complete resection, there is a higher increased risk of lymphovascular invasion, which can be up to sort of 20%. So even though the margins are negative, patients may come back later down the road with sort of lymph node, positive lymph nodes. So I think ESD or endoscopic resection is sort of ideal in early cancer, depending on the size, type of cancer, and the depth of invasion.
Awesome. Now I want to go back. This is a question that there was a similar question, but let's go to like maybe Amy and Brian and Angela. can you talk to people a little bit about going from diagnosis to treatment and how maybe your symptoms may have changed, maybe symptoms you had when you were diagnosed, and then as you receive, let's say, systemic chemotherapy or treatment, how those symptoms may have changed? And maybe we'll go with Angela. We haven't heard from you in a few minutes.
Yeah, absolutely. I sort of presented to care in October of 2020 after a few months of dysphagia and sort of early satiety. When I was diagnosed in January 2021, and I immediately started systemic chemo. And within, I'd say, just about a week before my second chemo, my esophagus had opened up enough where I was able to eat again. And it felt like a miracle, because I was down to the point where my esophagus was 6 millimeters in diameter, and I would come home from work and I would only be able to like lick peanut butter off of a spoon, and that would be my dinner. So I had lost 40 pounds. And so, going from feeling weak, skeletonized, to just having that ability to eat again, I thought chemo was the best thing ever.
And what about you, Amy?
Well, I went through a back door because I dialed 911 one night and got rushed to the hospital, and I had emergency surgery and had a Billroth 2 partial gastrectomy. So I basically had lost enough weight. I was like 95 pounds after the surgery. So I had to gain weight, recover from the surgery in the end of June, and start chemo in August. So I gained the weight. I got back up to about 123. Started chemo. Horrible for the next 8 months. I just can't describe it in proper adjectives. Nothing felt good. Nothing felt good. When I started immunotherapy and finally the chemo wore off, it was like a game changer. You see me what I look like now? I was a stick figure, 95 pounds 4 years ago. There's nothing I could say nice about chemotherapy. But immunotherapy and targeted therapies are really our future.
I think that's a great comment. And before I get to Brian to comment, I will tell you from my observation, and again, Dr. Moy isn't here, so I'm going to play, medical oncologist in addition to surgical oncologist, is that there's a big difference between getting chemo when you still have your stomach. And like Angela said, if you have your stomach and you're having problems swallowing and eating, a lot of times the chemo, even though it can make you feel like crap, if it's shrinking the tumor and then you can eat and drink and gain weight, it's a paradoxical kind of effect, right? Where ironically you feel better. The difference is getting chemotherapy after surgery, for the most part, it's horrible because you don't have the same ability to kind of deal with the chemotherapy in terms of nausea, vomiting, appetite, etc. And if you look at a lot of the studies that have been done over the last couple of decades, the number of people that can tolerate chemotherapy after surgery or gastrectomy is rather low. And Amy, you're right. A lot of these targeted therapies, whether it's ramucirumab, whether it's Herceptin, whether it's immunotherapy like with pembrolizumab or whatnot, the side effect profile is much different. They're generally better tolerated. They still have side effects, right? Herceptin can hurt your heart. Immunotherapy can have side effects too. But in general, you're right. They're much easier on people. And Brian, I don't know if you want to weigh in on anything else that Amy or Angela kind of said and kind of their views of chemotherapy being slightly different.
Well, I had a similar experience with, as Angela talked about, where when I started chemotherapy, I was in a lot of pain in my abdomen. I had difficulty swallowing, and I would say within a month after I started the chemo, the tumors were obviously shrinking, which, as you said, Dr. Davis, as the tumors are shrinking, it relieves a lot of just pressure and pain, and then I was able to begin to eat a little better, and the pain was going away. And so I was noticing pretty immediately that a lot of those symptoms were starting to go away. Now, however, I started to get neuropathy and nausea and fatigue and all that stuff. So it was a trade-off, I guess. But and I do also, I just want to second what Amy said about immunotherapy and targeted therapy and how that's, I think, really just the way of future cancer treatments. I was on a targeted chemo last year called Enhertu, back when I was HER2 positive, and it worked extremely well for me in the months of February and June of last year. It worked so well that at a certain point it stopped working because there were no more HER2 cells to target. However, I still had some other cancerous cells that then grew that the Enhertu didn't target. So and that's puts me where I'm at today.
I think your guys' insights are spot on, and this is really important for people to understand kind of the differences. Not all chemo is chemo, right? Now there's a question down here that I think is going to bring back in both Megan Roberts and Dr. Leung, but I'm going to start off with it. And this is the question. Nicole asks, I fall into the bracket of no family history of gastric or breast cancer, but I carry the CDH1 gene mutation. And my current doctor recommends a total gastrectomy within the next year. How does one decide whether to do surveillance or a total gastrectomy, and what are the current recommendations for people like me? So I'm going to use the pleasure of the podium to answer this, because this is, I don't know, I have this conversation every day. So to Megan's point, you know, there's a group that I'm part of, the IGCLC, where we make recommendations. And the recommendations basically say if you have a CDH1 mutation and you have a family of stomach cancer, you're recommended to undergo a gastrectomy, right? Because you're at much higher risk to get stomach cancer, and we don't want you to get stomach cancer, and the best way to prevent it is to take out your stomach. Now, a little caveat there is to say, well, if you don't have a strong family history of stomach cancer, you should consider gastrectomy. So a little bit of a waffle kind of word. And the question is, well, how do we know if you truly are going to get it or not? And the problem is we don't know. Just because you carry that gene mutation doesn't mean that you're gonna get it. It means you're just at higher risk. And what we're learning, and Megan mentioned this earlier, is that there are people out there with a CDH1 mutation, and you look at their family and you can't see any evidence of anybody in the family ever developing stomach cancer. But does that mean that you aren't at risk? And we wrote a paper recently that shows that even in families with no evidence of stomach cancer history, you can still find early cancer in their stomachs. So it tells us that, yes, you're still at higher risk. We just don't know exactly, you know, what that risk looks like in terms of, are you going to get it over time? So what are your options? I would say that you still are, it's reasonable to consider a gastrectomy. Nobody's going to fault you for that, but gastrectomy is a big deal. And I think surveillance has a role, and I think it's relatively safe. And so what I would say is this is not an easy answer. This is not a black or white kind of situation. You have the mutation, you are at higher risk, nobody knows for sure. Gastrectomy or surveillance. And I think right now most people, and Dr. Leung can comment on this too, out there probably don't have a ton of faith in surveillance. I understand why that is. We need more data. But I also know that a lot of people underappreciate the long-term consequences of total gastrectomy. And Amanda can probably comment on this too. So with that said, back to you, Megan. What do you say for somebody with no family history, and what should they do?
So my approach is always to provide the data, which I think you just covered nicely and we kind of discussed earlier, right? In this instance, the recommendations currently are to at least do the upper endoscopy and the screening and consider gastrectomy, right? I think the conversations to have with patients from a genetic perspective, or at least like the counseling part of the genetic counseling, it is really distressed as a personal decision. And this is something that I can give you the data and I can point you in the right direction. But it's gonna come from within in this situation to decide what is best for yourself. And so sometimes my role becomes more of asking questions and helping this person figure out where their head is at. And so what one patient may decide may not be best for the next patient in this situation. And so I apologize, I don't have like an easy, this is what you should do, this is the best answer. But again, it's provide guidance based on the most current data and then help that person make the decision that's best for themselves.
I think that's perfect. And we only have a few minutes left. Dr. Liang, what would you say to somebody, or what's your comfort level with, let's say, endoscopic surveillance for somebody with CDH1?
Yes, I think there's no right or wrong answer that this should be individualized to the patient. It also depends on a lot of other factors. There's sort of comorbid status for surgery. Are they willing to undergo very close surveillance, given sort of that ongoing risk of developing cancer at any point, if they sort of vouch for surveillance. I've done sort of surveillance for these patients, and I do very sort of careful exams under high definition white light endoscopy, under narrowband imaging, under magnification, just to see any subtle changes in the lining of the stomach, and take sort of targeted biopsies of anything that looks abnormal, and also taking sort of targeted or mapping biopsies throughout the stomach. If anything comes out positive, I can always go back and see, is there something early enough or concerning enough that I could do an endoscopic resection? But again, sometimes these lesions can be very subtle, and there's a risk of sort of missing lesions as well. So it's important to sort of understand both sides, have risks and benefits.
I think these are good points. I think the field is obviously evolving, and we're learning more, hopefully, as the days go by. I think we haven't gotten to all the questions, so I apologize if I've skipped over your questions, but I'm doing that on purpose because we're, trying to hit a lot of topics. One of the questions on here, which I think is really important, and this is to Amy, Amanda, Brian, and Angela, any words of hope for others who are on a similar journey, or any valuable lessons or words of wisdom? And I'll start with Brian. Oh, Brian, I can't hear you. I think you're muted.
Sorry about that. Yeah, my dog was barking. I muted myself. Anyway, when I was first diagnosed, one of the first things I learned that I realized I had to do was I had to learn how to listen to my body. And I realized that for years I had not been listening to my body. And I'm talking about just very simple things like eating. Stomach cancer immediately disrupts the very simple act of eating. And there were days when I would only eat watermelon, or I would only eat rice, or but if you learn to listen to your body, it can help guide you through the healing. Another thing that I learned that helped me was it's okay to accept the help of others. And when you're going through stomach cancer diagnosis and chemo, it's really scary. And so if you're lucky enough to have others around you, whether it's friends, relatives, coworkers, whatever, allow them to help you, because it really can make a big difference.
Super helpful. Angela, what about you?
I would say, for me, knowing what your goals are, like set realistic goals after you get your head around the initial diagnoses. So I took a look at where I was, and I immediately got into clinical trials. So I had my goal was gastrectomy, because I had heard over and over that if you sit around a table of stomach cancer survivors, one thing they all have in common is nobody's got a stomach. So to me, I felt like that's going to be, my goal. But I knew that I was going to have to break it up into smaller steps. I had to do the intravenous chemo first to get to the HIPEC trial to get to you. And so that's how I structured my whole last year, was fighting to get to you. And so that's what I would say, is set realistic expectations for yourself, but never forget where you're headed, because there are times where it'll get hard, and it'll get lonely, and it'll get, it gets deep. But if you have that goal in mind, you can get there. So don't give up hope.
I think that's great, and I'm glad you found me. Amy, what about you?
I guess what all they all said was perfect. The only other advice I'd say is don't ever take off your boxing gloves. That's it. You keep them on. I still have them on. I'm here getting Keytruda number 50 today, 50. So
Wow.
don't let up.
And Amanda?
Well, I agree with all of that. And I also wanted to say that while it's hard, it's really important to try to keep a positive attitude, because like Angela said, it can get dark, and finding something positive to focus on is really helpful. You know, the fact that you're here is the one that I always go back to, and that's been really helpful to me. So.
Well, listen, I think having you guys on today was awesome and super helpful, and I know that everybody appreciated your insight. And then Megan Roberts, who's really an expert in kind of CDH1 in the world of hereditary gastric cancer, thank you. And then Dr. Leung, I may be calling you up to get your help on some advanced endoscopy. So it's great having you all here today. I think we're gonna call it quits for this section, so everybody can take a lunch break and then tune into the afternoon sessions. So thanks again, everybody.
Thank you.
Thanks. It's an honor to be here.